So our next panel is the role of testing in diagnosis and treatment planning. So this is always quite a contentious issue because obviously the NHS don't recommend any testing. So I'd like to invite our panel up onto the stage, starting with Professor Mark Bircham-Mackin, who's a Professor of Molecular Dermatology at Nuclear University.
Great. Got Sasha Langstrom, Specialist Dietitian. And an MSc in Advanced Dietetic Practice.
And then we've got Dr. Mayoni Gunaratne, who is the founder and medical director of Human Health and Skin Fit. And I just also wanted to wish Mayoni a very happy birthday.
With Dr. Shasi Prasad, experienced GP, specialising in women's hormonal health and weight management.
And then we've got Yulia Minchin, who's the founder and CEO of Willbe, because unfortunately Dr. Vanessa Emsley couldn't make it today. So thank you all very much for joining us. So, testing, contentious issue. What I'd like to ask for whoever wants to take this is, how has the advancement of diagnostic testing transformed the approach to menopausal care and treatment planning in recent years? Who wants to take this one? Mayoni, do you want to start?
Yeah, I was hesitant because I'm biased, I guess, because I do test, I don't guess. I'm of that church because I've seen it go so badly wrong when it's left to chance. But I'm very conscious that a huge amount of our patients are entering the service through the NHS, and we have to be respectful of our colleagues who are also still working within those systems. But for me personally, I think there is so much that we don't know, and I think I had a conversation with a patient literally this week. I put it on my Instagram stories where I was ranting slightly, where this woman had gone to her GP, had been told absolutely point blank there was no chance of her being perimenopausal, despite her bloods clearly demonstrating that, based on her progesterone to estrogen ratios, and her symptoms, most importantly. And she came to me bewildered and confused as to why she was so deeply anxious and scared. And I think there has to be a balance. I totally understand that within the NHS there are the constraints, but I think I would encourage anyone who is within that system to look and do some training and understand better. You know, I went to medical school 30 years ago, and we weren't taught this stuff. No. It's fine to say we don't know. I think that's the point. It's fine to say we don't know. It's fine to go and refer on. It's fine to also have training. But please don't give out wrong information to patients.
So, Professor Bircham-Mackin, did I say that right?
Yes.
Thankfully. So you've done some work with mitochondrial DNA as a biomarker, and that's absolutely fascinating. How do you see this technology being integrated into routine menopause care in aesthetics?
Thank you. Yes, I've spent, I think it's about 30 years of research on mitochondria. And for those, if I can remind you, remember mitochondria, the batteries of the cell, all right, they're the power packs of the cell. So anything to do with metabolic energy, things like that. Mitochondria at the center of aging process. And we know the fact that in menopause there are effects on obviously collagen, but there are also direct effects of estrogen with mitochondria. All right, and so obviously when you've got less estrogen in your body, then therefore it's going to affect your batteries of your cells. All right, and obviously that will lead to making more collagen and everything else. So there are actually estrogen receptors on the mitochondria, right, believe it or not. And so actually estrogen will actually boost mitochondrial function. It will actually also make the mitochondria leak-proof, all right, which basically makes them more efficient because actually they get holes in them, and so estrogen helps them to be like a tight bag of content. And also the fact that estrogen will actually help to promote mitochondrial function, which will help your skin to stay healthy, right? And so mitochondria in skin actually are at the center of why our skin remains healthy, because you need the energy to make all the stuff, right? So the reason why bringing, and so actually done a lot of work on that, formed a spin-out company called Skin Life Analytics, which is on stand 38 in the Balmoral room. What we're able to do is to test and track the state of your mitochondria in your skin with a non-invasive swab, which will enable you to then just to go on a tailor-made journey to monitor your patient's skin health. And actually walk with them and empower them to do that. So we've done that in a lot of samples and a lot of patients, but the opportunity for the menopause scenario is immense, and we were talking about that earlier, weren't we, in terms of the metabolics. Mm-hmm. The fact that because of the effect of estrogen directly on the mitochondria, and because of the mitochondrial role in skin health, particularly looking at effects in menopause, in kind of skin dryness, skin fragility, and wrinkles and things like that, and more susceptibility to environmental changes, the mitochondria will be a sentinel to reflect the changes in your skin. So if you've got your particular intervention and you're wondering whether or not it's working or it isn't working, mitochondria will give you the ability to monitor that as you go along. Does that make sense?
Yes.
I was thinking, testing we think is a way forward to monitor patients. What you're saying there is very specific and cutting edge. It's very exciting. It might not be the first thing people do when they start offering menopause treatments. And is it likely that everyone here does different testing? Are we all doing exactly the same tests, which we can then take to another practitioner? Should you move house or move country? Are we doing the same things? I wanted really specific to ask Sasha. Sasha, now you, nutritional genomics. Now, I sense you might come from this from perhaps a different angle in terms of testing. So maybe what might you do differently to, say, a straightforward doctor just leaning into HRT therapy? How might you be different in the way that you test?
Well, not everybody needs nutritional genetics testing. It's not a requirement for everybody.
What is it? Maybe just give us a one-liner. Okay. What actually is it?
Well, you could do it by cheek swab, and the report comes back. You could test various aspects of your genetics for various different things, but I most focus on nutritional genetics, and so the report comes back and it gives you some predictions based on which dietary changes will be the most effective. And I think, I've been in clinical practice now for nearly 25 years, and the how people change is actually, for me, really interesting. And what I see is that there's so much information out there about nutrition in particular, and people can become a little bit blind to it. But when it's personalized to them, then they are much more able to take that step to make the lifestyle change. It's not an absolute requirement for everyone, but for people who are really stuck, either because they've got a lot of health issues and they don't know where to start with their nutrition, or for people who really want to fine-tune what they're doing with their nutrition, it works really well as a starting point for making changes. And I'm a big fan, because we're all short of time and energy and resources, I'm a big fan of lifestyle changes, little lifestyle changes that have the biggest effect. So that's why I really like nutritional genetic testing. And the thing is, if you get a good one that's got a broad spectrum of information, it's sort of one and done, right? Because the patient might come to you with questions about weight loss, which you can help them with, or questions about digestion, which you can help them with. But a good report will also have information that might be useful to them in 5 or 10 or 20 years if their blood pressure goes up or their cholesterol becomes dysregulated. Mm-hmm. And these sorts of things are very effective because it's, if your blood pressure goes up and you're going to put the discipline in to reduce your caffeine and salt intake, it will be more effective for some people than for others. And it's the same with dysregulated cholesterol. You know, if your LDL is going up and your HDL isn't quite where it should be, then, you know, there are certain interventions like exercise, changing carbohydrates, changing fat intake, and some of those interventions are more effective.
Julia, you wanted to come in.
Yeah, I just want to add, because I believe the personalized healthcare era is here, and we definitely should leverage that knowledge. The cultural awakening is happening, scientific breakthroughs are happening, so understanding how your body works from a genetic point of view, I think it's an amazing starting point, because let me give you an example. At the last panel, doctors were discussing why some people might not be getting all the benefits from estrogen replacement therapy, and actually one of the reasons that could be is a woman having an MTHFR gene mutation and a SLOCOM gene, which are responsible for estrogen detoxification. So what is happening currently, because nobody is testing those specific genes, at GP settings, a woman starts trying estrogen, nothing is working, her symptoms are not reducing, and she goes back to the GP, and the GP tries to increase the dose. And actually, this is really counterproductive, because the reason why her estrogen is not working is because she's not detoxifying it, and there is an estrogen buildup happening. So it's really important to empower women with that knowledge and understanding how their bodies work. And for example, we have a client in our practice. She is a former PT, nutritionist, doesn't drink, doesn't smoke, exercises. She tried to do perimenopause naturally, like she was cutting things out of her life. Nothing was working. Until she tested her genes, until she realized that she has problems with her methylation cycle, which we supported with the right form of vitamin B. It made massive change to her overall well-being, and this is the beauty of personalized healthcare that probably everyone should start considering. And the things are changing. As I said, personalized healthcare era is already here. So it's just the matter of time until it will be widely adopted, but we're here at the forefront of that. And me as the founder of a gene-based proactive healthcare platform for women, I can connect you to our researchers, experts in longevity, to help you integrate their testing into your clinics.
Thank you. May I only just quickly, and then...
It was just to say, I disagree with you, Sasha, I love you, but I think everyone should have genetic testing. I really do. I think that in my kind of sort of John Lennon-style view of medicine and the future of health, it is, epigenetic testing will be absolutely
I want to pick up on that, and Shashi, I'm going to ask you.
So diplomatic about it, but I do agree.
We're talking about testing, and some of these tests are actually really, really expensive. Yes, they give you a wealth of information, but as people starting out in providing these sorts of services to their patients, how would you recommend that they go about integrating these into their practice? That's for you.
Yeah, I agree with the panel. We are moving away from, one size fits all, lot of guesswork when you're giving treatment, to more towards precise testing and personalized approach. There's a minefield out there about what tests are available. It can be quite expensive, especially in the UK, where it's not covered by insurance in most of the areas. So I think when we are setting a practice, we have to think, what is it that you want to offer to the patients? And then start from that. Are we looking for hormonal health, perimenopause, menopause? Then you start with the ovarian profile, ovarian hormones, FSH, estrogen, progesterone. Do you want to add in thyroid? Often in a midlife women, there is a big overlap of perimenopause, menopause, and thyroid issues. Do we integrate that? Stress and not cortisol, I think you'll all agree, big problems. Do we add that in? More genetic testing. There's lots all there. Dutch plus testings, urine for metabolites. So I think deciding what you want to offer and then stagger it in and start training. Obviously, all these testing would require training for the clinicians yourself. collaboration with the service providers. So we would start from there.
Brilliant.
Yeah. Oh, sorry. So yeah, just picking up on the fact that you highlighted, you know, it's becoming more personalised, more tailor-made. The previous, I think it was Mandy that used the word habit stacking, which I quite like. It's to do with our lifestyle, and we've been talking already about what we can do together in terms of our expertise. So it's not just, you can't do it all on your own, you have to work with other people, you have to have a team aspect. And so there's this whole aspect from, you know, in terms of nutrition, I've published quite a bit on nutrition and, you know, benefits to skin, things like that. So I'm a big believer in that. It's, you know, the kind of beauty from within. It's the whole aspect of the genetic testing. It's the teamwork, and it's bringing that into that tailor-made aspect. And I guess going back to the technology that I was talking about earlier on the mitochondria, it's a world's first technology. No one else is doing it, but I can't do it on my own. So it has to be with it has to be with expertise of the panel here, expertise of people in the room. You know your patients better than I do. It's a case of bringing it all together so that we can work together to actually empower the people that actually matter, that are experiencing those things. And so I think bringing world-class technology into world-class expertise is the secret, and actually provides that tailor-made expertise.
I want to ask you as a panel. So, I mean, we've got all these amazing tests, and whenever I go onto my lab's website, there's often a new test. I'm thinking, oh, wow, this is going to tell me a wealth of information. But in the UK, in the NHS, we're lucky if a patient gets a estrogen test, even more beneficial if there's a progesterone added onto it or testosterone. So how do you transition the patients that come to you from the NHS into accepting these more advanced tests?
I think for me, I start with a really good consultation and really understanding, literally walking a day in their shoes, because then we start to pull out, what do they want to change? What is it that bothers them the most? And that's then where I will direct their attention, their health behaviour change, and then testing. And sometimes a lot of my women who might be kind of C-suite, you know, highly driven, very stressed, but very good at dialing that down mentally, the dashboard of results that I show them starts to help them connect back to their body. So it may be then they start to realise that actually they are incredibly insulin resistant, that they've got huge levels of cortisol circulating, and that they really need to start a meditation practice. If I'd said that to them at the beginning, they would probably punch me in the face. So they need evidence. So I think evidence is really powerful in the form of numbers and dials and tests and results. Because it really reinforces the conversation. So if we keep having the same, I kind of know we're going to get there, but I need to show them the roadmap, and that's how I describe it, as the roadmap.
Can I just add something? So in 2024, the average waiting time for a menopausal clinic in NHS was we're in 2025, so it was 2 years. On average, a woman spends around £900 until she finds out what exactly is working for her. This brings me back to that question about the pricing for diagnostic testing and all of that. Well, actually, to do a genetic test is not that expensive, but it empowers you with the knowledge until the rest of your life, how your body works, what you need to do, what are the focus areas are for longevity. And there is another big problem, because the testing is not happening. Many women are trying BHRT, then they're stopping because some of the detoxification pathways are not optimized. And when they stop BHRT, they miss out on all the preventative benefits that BHRT has to offer. BHRT is the embodiment of preventative medicine. So this is why it's so important to test, to be data-driven, to connect the dots between all of the biomarkers that we have available to your unique biology.
Thank you, Julia. We're going to throw it open.
Quickly,
one more, yeah, sure,
one more, and then we're going to open the floor to you guys.
To say, you know, my daughter's been suffering with really bad panic attacks. She won't mind me sharing because she's getting better. She's 12, and she's also got quite significant history-related urticaria, stress-related urticaria. She's definitely peripubertal, And my husband and I have had a serious conversation about doing her epigenetic testing, not for anything other than to inform her and her future health, because how is she going to navigate stress? Is she going to have a full-on urticarial response every time she's faced with stress, which as a woman, she's going to have lots of? You know, and I think this is the future of testing. It's like empowering our younger generation to really own that conversation with their genes. Our genes are only 20% of our story, but that 20% can be quite big. Mm-hmm. So, you know, how are we going to navigate that?
Right. Any questions? Come to you in a sec. Which one there?
I gave it to Nicole. Yeah.
I would like to ask about testing during perimenopause. I work in the NHS, so obviously the evidence, according to what the NICE say, is that you don't test during the perimenopause for hormonal changes because they're very erratic. So it's very difficult to decide what to do with one test. So you're more dealing with the symptoms. And in 95% of the patients who you prescribe conventional HRT, it actually works. So it's about 5% that you have, 5-10% probably that have issues and probably seek private care. So what are your thoughts about testing in the perimenopause and how you interpret the results?
Can I be really controversial again and say that part of the reason we don't test in perimenopause is because what do we do with that information? Mm-hmm. Because the reality is your progesterone falls off a cliff pretty instantly. Your testosterone starts to fall off a cliff. It's very difficult to prescribe progesterone on its own. Women are offered the Mirena coil as their first port of call. Do you know what I mean? It's like, what are the options? Because the NHS is a population-based medicine. You know, it's beautiful. I worked in it for many years, but it's population-based. This has not got the capacity for the personalisation that we're talking about. So,
yeah. And I find
what do we
as
do
well,
with that information?
I mean, a lot of my early perimenopausal patients that I see privately, I will give them a low-dose progesterone on its own to try and counteract the symptoms of excess estrogen, which is what a lot of the early perimenopausal symptoms are.
Can I just add quickly, there is something fundamentally wrong the way we see menopause. First of all, why are we over-medicalizing it? It's a natural transition. Second of all, it's really important to shift the mindset that we're not trying to diagnose perimenopause. We're trying to understand what is going on inside the body and how to optimize that health. Because we believe that perimenopause is the biggest opportunity for longevity. If you fix all of the nutritional deficiencies, hormonal deficiencies, all of those things, it will set you up for increased health span. So I think it's about the mindset shift more than anything else.
Got
And,
a question?
if I can just add a line to that. So, you know, in the NHS, like, you know, when they say it's all about, you know, population medicine. But when we have to think, we think about every woman is different, their hormones are different, how they respond to treatment is different. So start taking, you know, step back and right back and understanding your hormones. What is normal for you? You know, that now, you know, like you say, if you want to create controversy, people say start testing from your mid-30s when you are in a good reproductive hormonal health. Track your hormones. How far do we go? And in perimenopause, one of the earlier changes is loss of progesterone, and these women may have normal to high estrogen. They get put on standard HRT with the standard or a high dose estrogen. They end up having side effects. So unless you test, how do you understand that? And how do you then convince your patients, explain the symptoms to them? And then, you know, you can then talk to them and the compliance will be better, the treatment options will be better. It might be that you don't need HRT, you have to do something else to manage your symptoms. So unless you test, how do you get that information?
Can I just follow up on that? And I know you're getting 4 responses to 1 question, so I guess that's the privilege of sitting on the front row. But anyway, but again, just building that picture, you were talking about genetic testing. We've talked about what you nutrition. I think we've skirted around the aspect of behaviour and wellness and anxiety and stress and things like that, and it builds the whole picture. Really of decreasing the amount of, you know, you can actually know your genes, but then you can be in a very stressful environment, or actually you don't sleep well. And we know the fact that, you know, sleep patterns, etc., will actually affect things like the batteries of the cell. And actually, we've done a lot of work with shift workers and things like that. You can actually tell the effects it has on your skin by measuring those mitochondria, right, using this non-invasive skin swab. So essentially, what we need is, it's having that information, and then as you were saying, it's not a population-based aspect, it's a personalised aspect, because you can have the information, but what you do with it, you can't just dump it on someone and say, these are your genes, this is it, get on with it. There needs to be a management part of it and a lifestyle, this habit stacking thing, where we're actually adopting good lifestyle patterns to actually then benefit, the menopause effects, but particularly skin and hair, and then finding out what that does and having those biomarkers to go with it.
Thank you. This is where holistic care and having referral pathways really comes into it. Right, a couple more questions. So there's one here, and then...
I think this has been a fascinating discussion, and it's a pity it's not longer, because I think that most of us probably do practice personalized care. We ask questions of our patients. Especially when we're dealing with menopausal patients, right? We're looking at their lifestyle, their sleep, their stress, etc. I agree with you. We want to expand the health span. This sounds like it's almost like more specific testing. You know what I mean? Because I don't think anybody, I'm going to assume everyone here, would probably be doing personalized consultations anyway, right? This is like stepping it up another level. So the word personalized almost makes it sound that's new. I feel like most of us are doing that. But very fascinating, all of that. I wanted to ask about the testing. Is there any repercussions with insurances depending on what comes back, as you find, you have a genetic marker for this or that? I know in the US, I think there's been some noise about insurances. Sometimes they're not covering you for certain things. Is that some of the genetic tests? Are you able to tailor it? So I don't know. I just think it's a fascinating area where it could come back to bite some patients where they may not get insured because they get something found.
Well, I think there's so many different types of genetic testing. So if
100%.
if you focus on, say, nutritional genetic testing, you're not really looking for certain things like ApoE, you're not looking for the BRCA gene. Those kind of things are different. You can test those for sure, and that leads you to other information, but then you really have to have somebody on your team who's really strong with interpreting genetic tests and doing the coaching and all of that around that. But you can do genetic testing where the information isn't scary. There's always something that's actionable. There's always something that is lifestyle-based rather than the kind of doom and gloom of some of those tests that are out there. So you do have to pick and choose. It's a great question.
I think also some of the SNPs, so the CYP SNPs, are very, very strongly linked to how we metabolize estrogen. And I think this is a real space for litigeny. I know that in the US, there are certainly practitioners who have been sued when they have known the nutrigenomic testing results and patients were still prescribed estrogen. So that's why I think fundamentally, that I go back to my original thing, I think everyone needs that epigenetic testing.
We're going to go to Claire first and then Hugo. We'll leave you till last, Hugo.
I think it's absolutely fascinating and completely related to that question there. So as an independent nurse prescriber, which I think a lot of us are in the room, how do we get involved? Where do we go? How do we upskill ourselves? Who do we get the genetic testing from? Which ones do we look at? What are our options? I think a lot of us are probably thinking, this is amazing, I want to do this, but how do we do it?
So actually, this is what we do as a company. We just recently developed FemGene genetic testing, which is the first test on the market which looks at meaningful S&Ps for women going in through perimenopause and menopause. While we can provide training, we can also work in collaborative manner with aesthetic practitioners, with functional medicine doctors to open the door to all of you here into longevity industry, which is forecasted to be valued at 30 billion by 2040.
Thank you.
I think going back to the previous question about the legalities of it, and also combining your question with genetic testing, we've just exchanged. It depends on with the single nucleotide polymorphisms, the SNPs that you're measuring, that's often based on risk ratio and odds. And there are different variety of linkages with the potential clinical outcome. But it also then is linked to the claims that you have as well. Depends what you're claiming based on that, and I think that's important. And with nuclear genes, you can actually know a gene, like the genes you're testing for, and I've looked at over the years. It's not just a gene; it's how it's switched on. So is it switched on fully, partly? You've got methylation. You've also got, in terms of polymorphisms with nutrition, you might like tomatoes, but you might not be able to process it because you haven't got the right polymorphism to do that. And so I think you've got to look at the whole genetic profiling in that context, which is why I spent 10 years working on skin with nuclear genes and then thought, well, actually, I've got a whole history on mitochondrial genes. Mitochondria reflect the stress, the crime in the cells.
That's great, Mark. We'll just move on one last question because it's short of time. Where was the last question?
Here you go, at the back.
Thanks, Tom.
Hi. Just need to remember the title of this lecture, the role of testing. Forget the esoterics for one moment. We are all scientists here. If a patient of mine came to me with increased thirst and polyuria, you think, oh, that's diabetes, right? You do a urine test or a blood test. If you came to me with chest pain, palpitations, shortness of breath, my ankles are swollen, you think, well, that's cardiac. I'll do a pulse, blood pressure, EKG, etc. This is science. If you come to me with your hair falling out, I can't keep the weight off, my vagina's dried up and I want to stab my husband in the back. Oh, I'll tell you what, we'll give you some sertraline, love, it's just your age, fine.
Yeah.
Okay, well that all goes horribly wrong. We need to be testing. No matter how you do it, it's saliva, blood.
I think all of us agree with you on that one.
But it's not happening at a level out there in the general public.
And you get chastised for testing when you do it privately as well by the general public. So we do need to change that mindset. At the first Menopause and Aesthetics, someone said, if you're not testing, it's like driving a car blindfolded.
Yes.
Yeah, what can be measured can be improved.
Yeah.
Good.
Yes.
So I think we are going to
Can I just do a
really
quick
quickly
shameless plug for human health professionals, because I've, just in answer to your question, I've basically launched it for the last 2 years, but we've got our first in-person training event on the 6th of March in London, where you will get the opportunity to really understand a deep dive into the consultation process, how to manage acne and rosacea from a cell-up approach using tools such as this, and also how to introduce a wellness practice to your own practice. And we'll be doing more of those sorts of events through the year.
So with that, it is now coffee time. So I'd like to thank my wonderful panel for joining us. We never have enough time on these, so grab them in the breaks if you've got more questions.